Welcome, everyone. We're very excited to have you for this webinar on COVID-19 vaccine delivery in Asia, hosted by the International Vaccine Access Center and supported by the Asian Development Bank. My name is William Moss, and I'm the director of IVAC, a center within the Johns Hopkins Bloomberg School of Public Health here in Baltimore, Maryland. IVAC's mission is to create a more equitable world free from adverse health, economic, and social consequences of vaccine-preventable diseases. IVAC was commissioned by the Asian Development Bank to review lessons learned in 6 developing member countries to identify challenges and best practices in COVID-19 vaccine delivery to help inform future investments in pandemic preparedness. We have an interesting program that will consist of presentation of research findings, a panel discussion, and time for questions and answers at the end. I will start by introducing our speakers and panelists. Our first speaker is Sherry Morgan. Sherry is a research associate at the International Vaccine Access Center and the project coordinator for the work with the Asian Development Bank. She has an MPH from Emory University Rollins School of Public Health and is a global health professional with experience in Asia and East Africa who specializes in qualitative research methods and global infectious diseases. Sherry will present an overview of the research objectives and methods. Our moderator for today's discussion will present our research findings is IVAC's Lois Priverdum. Lois is the Director of Adult Vaccines at IVAC and focuses on immunization policy issues across the life course in a broad range of countries. She has provided technical support on new vaccine introductions and has worked on a variety of vaccine topics for more than 25 years. Lois has advised stakeholders on adult vaccination, including community engagement and vaccine acceptance in older minority populations in Baltimore City, and on community acceptance of COVID-19 vaccines in both the US and globally. We have a very distinguished panel, list of panelists. First, Dr. Qasim Kubanov is a consultant on public health and the epidemiology of communicable diseases in Tajikistan. He is a member of the National Technical Working Group on implementation of the National Deployment and Vaccination Plan. As a public health expert, Dr. Kurbanov has provided consultancy services to the Asian Development Bank from 2020 to current on responses to the COVID-19 pandemic. Naeem Golda is Deputy Director within the Department of Regulatory Inspection at the Director General of Drug Administration in Bangladesh. He holds a Master of Science in Biochemistry and Molecular Biology from the University of Dhaka, and during the pandemic, he worked in the administrative sector where he performed marketing authorization as well as regulatory inspection activities. With him is Salah Uddin, the Director for Marketing Authorization for the Directorate General of Drug Administration in Bangladesh, and he will also join us as a panelist. Our next panelist is Dr. Tadine Dorji, who has worked for 27 years within the Ministry of Health in Bhutan, where he also served as the Director for the Department of Public Health. During the COVID-19 pandemic, he headed the National Surveillance Team and was a member of the Technical Advisory Group closely involved in the rollout of COVID-19 vaccines. More recently, he has worked as an independent consultant in public health. And then we're lastly pleased to be joined by Dr. Dinesh Arora, a public health expert with over 20 years of experience in South Asia, the Middle East, and North Africa. He has a medical background with specialization in public health and economics and has dedicated his career to researching, implementing, and advocating for evidence-based strategies to address public health challenges. At the Asian Development Bank, Dr. Arora handles a diverse portfolio, including work on human resources for health management, pandemic preparedness, adult vaccination, manufacturing and regulatory strengthening, and pandemic preparedness. So you can see we have vast expertise and experience across our panelists. I'm going to turn it over to Sherry for the first presentation.
Thank you so much. So this presentation is going to go over the objectives and the research methods for this technical assistance with the Asian Development Bank. So the main objectives is to assess the lessons learned to share with other countries for future pandemic preparedness. And all of this work has been done in the Asian and Pacific region, which I will further discuss in the next slide. We are to understand best practices and challenges related to the COVID-19 vaccine delivery efforts in the region, including policies and politics, financing, supply and procurement, community demand and engagement, manufacturing, vaccine safety, human resources, and risk communication strategies. Through this work, the goal is to provide recommendations to the Asian Development Bank on the types of investments or technical assistance that could strengthen preparedness for future pandemics in Asia and the Pacific. Next slide, please. For the methodology of this technical assistance with the Asian Development Bank, 6 countries were selected and key informant interviews with 136 respondents were conducted. Those 6 countries include Bangladesh, Bhutan, India, Mongolia, Pakistan, and Tajikistan. For the key informant interviews across each of these countries, we reached a total of 136 respondents across a number of different roles, such as regulatory, government officials, implementation partners, and laboratory specialists. In addition, we also interviewed with regional and global vaccine safety experts, as well as manufacturers, and we identified all of these stakeholders through a snowball approach. A semi-structured interview guide was also developed to identify the facilitators, the challenges, those best practices, and the lessons learned throughout the COVID-19 vaccine delivery efforts. All of these interviews were transcribed, translated if needed, coded, and a thematic analysis was conducted. And all of this was also supplemented with a literature review. The recommendations for the areas of future strengthening to be made to ADB, and these findings have been summarized in individual country case studies, including an overall synthesis document, which are all currently in review. So for now, I will turn it back over to Lois Preverdom, Director of Adult Vaccination here at International Vaccine Access Center.
Thank you, Sherry. And I really wanted to thank all of the stakeholders that participated in this study and informed our work, and ADB for making this all possible. We really found a wealth of information and many strong examples of dedication, ingenuity, and planning to get things done. It's hard to distill all of the findings that we have in 15 minutes, but that's what I'll attempt to do. And you will have the benefit of hearing more from our distinguished panel afterwards. Next slide. So I just wanted to start off orienting ourselves to what was the performance of the countries. So as you'll see here, most of the countries were well above the world average. And this is a graph of the number of people that received, the share of people that received 1 dose of COVID-19 vaccine. There were a couple of countries that took a little bit longer to reach the world average, or according to this graph are not showing this. But I do want to point out that there is a difference in the way that these numbers are presented. And the denominator represents the total number of people who received 1 dose. So for the countries that have a relatively young population, like Pakistan and Tajikistan, the share of vaccine coverage would actually be much higher in the adult and target populations, as I'll show in the next slide. Next slide, please. So this is a graph of the age distribution in various countries. And what you can see below is that the countries are really, that we looked at, are really typical, a little bit more typical of an Asian population, but of LMICs still. The age structure is slightly younger. So you'll see in the pink bars at the very end, the proportion of people 65 and above, and the brownish bars are people 25 and above. And we're finding that there is a very, very significant portion of adults. So this speaks to the importance of making sure that there is prevention activities going on in each country for older adults. And as I mentioned earlier, if you take a look down at Pakistan and Tajikistan, those are two countries that are trending younger. Next slide, please. So we looked at what actually influences both performance and approach. And there's several things that I'll go over through the course of the presentation. We'll discuss different governance models and how those vary from country to country, the strength of the vaccine program and whether there's an adult vaccine platform, speed and scale of vaccine uptake, local vaccine manufacturing, human resources for health, and public health and vaccine confidence. Next slide, please. So how did they do it? There's some commonalities across countries. All of the countries that we spoke to showed strong central leadership and all had a command and control operation. One feature was that there was also strong partner support in each of the countries that helped them get through the pandemic and really make sure that they got the vaccine coverage that they did. They all leveraged their experience with routine immunization. There was dedication amongst health workers. There often was not enough of the right people in the right places, but we did see that people came to the challenge and really worked hard and very long hours. There was also something that we saw was use of a proliferation of digital tools and innovations. And these are things that we think are important to carry through beyond the pandemic. Next slide, please. So let me start off talking about some of the differences we saw in governance. One approach is not necessarily better than the other, but it needs to be optimized for the country's own context. For instance, we saw two countries, India and Pakistan, with decentralized governance, meaning that certain parts of the program were left to the provinces for Pakistan or the states for India. This has both advantages and disadvantages. And the goal is really to optimize the local knowledge of what will work while still ensuring oversight to reduce the levels of inequity. In the centralized models we saw two different approaches, including Tajikistan and Mongolia, who benefited from a strong culture of vaccination, and were able to put mandates in place in the case of Tajikistan. And in the case of Mongolia, they relied on very early success with strong control measures and quick action to get the vaccine in the country. Bangladesh and Bhutan took a very different approach. And while they were still centralized, they did not use mandates and included a wide variety of sectors in their planning and implementation. Next slide, please. One of the areas that we saw in large countries in particular, although this also happened in some of the smaller countries, in particular Mongolia, that there was an important role for the private sector. It didn't always work out as planned, but it's viewed as an opportunity to reach older populations or those that don't really have access to the public health system or don't have trust in the public health system. If done right, the private sector could really expand access. However, there are a number of concerns, and these include equity, whether it be the private sector being able to access the vaccines, or the other way in that the people that are able to access the private sector have access to those vaccines before others. There's also some concerns about pricing. We saw a very wide variations in pricing in the private sector, and reducing those variations would be important. There's concerns of consistency and quality of service and reporting. The private sector needs to be engaged in reporting, not only of adverse events, but making sure that they're reporting all of the activities or the experiences that are happening in the country. Next slide. In terms of speed and scale, we also saw a number of different examples. So 3 different examples where we saw fast and rapid uptake. We saw moderate speed, but uneven uptake, and in some cases, delays. And in the case of Tajikistan, how, as I mentioned earlier, we do believe that the data don't necessarily represent the full situation where there was uptake in older populations. Next slide, please. So there are 3 different procurement approaches that we saw. These procurement approaches include the first category over on the left of Bhutan and Mongolia, where there was very proactive procurement and rapid uptake. These countries are relatively small, so they were able to do something different than the other countries. And as you saw early in the presentation of the graph, both Bhutan and Mongolia had very rapid and steep uptake curves, so they benefited from that. Bhutan benefited from a number of donations. Mongolia also benefited from donations and bilateral deals. Then there was the combination approach. In India, there was a variety of vaccines that were manufactured in the country. India also donated vaccines to other countries, although that didn't necessarily go as planned during the Delta wave, and they had to discontinue that donation. Bangladesh did bilateral procurement, donations, and COVAX. They had 9 different vaccines that were approved. So both India, Bangladesh, and even Mongolia and Pakistan had a very large number of vaccine approvals. In Pakistan, we also saw, similar to Bangladesh, but what was added there was fill-finish operations of CanSino Bio, the Chinese manufacturer. And then finally, for Tajikistan, what we saw was a model where they waited and went through COVAX, and they were the first in Central Asia to receive the shipments from COVAX. But what we saw were delays. Fortunately, none of the delays were extensive, but you do have to take a look at the volumes of products that are coming and what that does to the uptake curves. And that's one of the reasons why we think we saw a lot of the variability that we saw. Next slide. So manufacturing is also a reaction to the lack of supply and a desire of some countries really to reach self-reliance. So supply was a really big challenge, particularly early during the pandemic. India was the only country only manufacturer at the time, with the exception of Pakistan, which did a little bit of fill finish, but not really a whole lot. And what they found was that their plan to basically supply the world did not go as planned, and that's a lesson in itself. But that was a huge advantage to be able to have the manufacturing base and the ability to supply their own country and other countries. And Bangladesh, as you'll hear a little bit later, is now planning to manufacture. There's several steps that still need to happen to get there, and you'll hear more about that during the panel discussion. And then Pakistan, as I mentioned, conducted fill finish operations. But there is a need still to conduct strengthening exercises of regulatory systems and pharmacovigilance across the manufacturing countries. And even beyond that, although the needs will be slightly different. But the most important finding here is really not to look at each country only individually, but look at where do they fit within the vaccine ecosystem. As what we're seeing in many of the countries is inconsistent demand, waning demand, inconsistent supply at times, and the potential for actually higher prices if the vaccines volumes are not large enough, or the ability to access the raw materials is not there. We need to also be concerned about having the right human resources and know-how to be able to conduct the manufacturing operations. And all of this can influence how sustainable a project is. So it's important to consider not only the individual operations, like the evolving industries in Bangladesh in particular, but the existing mature industry in India and the other industries around the region and around the world. There's also a need to consider both public sector and private sector because there's some important differences between the two. Next slide, please. So health workforce is one of the challenges that we saw in every country. There are examples of how these challenges were mitigated as well. And the number of a health workforce is not necessarily what the deciding factor is in terms of how well countries did. So you'll see over on the right-hand side a graph of, this is just an example of the density of nurses and midwives per 10,000. And there's quite a bit of variation. But what countries did was they used different strategies such as a volunteer workforce, used the private sector, used digital innovations such as remote training, telemedicine, teleconsultation. Those were things that we saw actually quite a bit of in Bhutan and India, and remote training in nearly all the countries. So those were things that really did help in addressing some of the health workforce needs. Training is really needed, and this was a common theme across all of the countries in public health and in handling emergencies. And sometimes the concern was that you had, people vaccinating or handling certain parts of the pandemic that really weren't trained in public health. They weren't trained how to handle vaccine hesitancy or talk to people within the population about the importance of vaccines. There were also some concerns around hiring timelines in the public sector. And an interesting and promising approach that is happening in India was the outline of the public health charter that identifies the roles of different individuals within public health, the needs for management, the supervision and retention, to just name a few. So having that health workforce plan for the public health sector becomes really important and something that countries may benefit from. Next slide, please. So vaccine confidence across the region was actually generally high, but there were small pockets of resistance that were emerging. And these resistance pockets are important. Communication is important. We need to be doing capacity building to make sure that this includes risk communication. Next slide. So there's opportunities for investment and technical assistance. We really do need to shift the focus from a curative focus to prevention for adults, develop regional solutions for supply security, improve service delivery, and that's an opportunity with the private sector, find new ways to address the human resource challenges, and integrate and sustain advances from the pandemic. Next slide. So in conclusion, countries really demonstrated what is possible and showed advances in innovation, awareness, and understanding of the value of vaccines that should be shared and leveraged. There's, as you can see below, areas where we think that further investments would benefit the countries and strengthen the preparedness of the countries. And it's important to think about the different investment priorities countries have depending on the typology. So thank you very much for your attention. And I wanted to invite the panel back to start the discussion. So if we could just get everybody's video on, and then start off with a few questions. So what I'd like to talk about are some of the lessons learned. I presented some of them, but there's many others that are coming from your countries. And let's start with Tandon. Bhutan achieved one of the highest rates of vaccine coverage in the world. What do you think contributed most to that? And what were some of the things that you struggled with?
Okay, thank you, Louis. In Bhutan, Bhutan has traditionally had a very high vaccine coverage like for traditional vaccines. So that was a strength which the country could build on. And also we had a lot of experience with mass campaigns in the more recent past, like introduction of various vaccines, which was also also very helpful. And obviously the political commitment, like it was very difficult to get the COVID vaccines at that point of time. So the political commitment to actually get the vaccines at all costs, so that also contributed to actually having the vaccines in place. And of course, like in terms of actual coverage, so having a whole of society approach, it was not just the health services which was only involved. We had the community involvement, like the local leaders, even other volunteers and other groups who were all part of like trying to mobilize people and trying to reach vaccines to the people. So I think there were a lot of different factors for the successes. And in terms of challenges, especially in for the messenger mRNA vaccines, it was very difficult. You know, Bhutan is a very although it is connected, it's a very difficult place to get to, and especially trying to get vaccines which are, I mean, very temperature sensitive, from maybe like from the US to Bhutan, and then have proper storage facilities, and then have them shipped out to the field to prevent wastage. I mean, that required a lot of planning. So,
Yeah.
I mean, those were the difficulties that we faced.
Great. Yeah, it really was quite an operation, and so many different people involved. So, you know, Bhutan really did an impressive job, because there were so many things that could have gone wrong, and really made it happen. So let me turn to Dr. Kosum. So Tajikistan shows a lower rate of coverage due to the age structure in your population, but for adults, you think you achieved a high rate of coverage. But there was still a number of challenges and successes that you could describe. What were the things that your country can be most proud of? And what were the biggest challenges that you needed to overcome?
Thank you, Lois, for giving the floor. So just with regard to your question, I have a lot to say, but to be short, because we have limited time, and so I will be short. So for the coverage, I would add that there was the problem of the denominator you clearly described. And just I have the data on my hand that the coverage of the first dose is about 100%. Second dose is 98, and the booster dose 87. So with regard to the challenges and the success which we can proud of, I would structure my response that first of all, the challenges, I think that the most may be similar to other countries, are the no vaccine in the first wave of the pandemic. The need to mobilize within the healthcare workers within the short time frame. But we did our best to succeed. And third is inconsistent capacity due to underfunded public health system. Deficit of the core response tools like the PPE, human resources, equipment, treatment protocols, etc. Lack of capacity to accommodate, I mean, the store and distribute some types of vaccines. For instance, Pfizer produced the vaccines. And lack of knowledge in their storage, cold chain operation, and administration procedures. Inadequate pharmacovigilance during the vaccination campaign, and myths about the pros and cons of the vaccines. But among the success, I would like to stress ability to mobilize quickly to the pandemic response, and involving key sectors like the policymakers, education, police, transport, ministries, and committee on emergency situation. Expediting decision-making process and coordination process through establishing national multi-sectoral task force, which plays the key role in coordination all efforts, and expert groups within the Ministry of Health. Timely application of the application to COVAX and APAX, and benefiting from the vaccine supply. By the way, Tajikistan was among the first developing countries who received the first doses of the vaccines. Adapting the cold chain capacity to the higher demand, and in some extent improving communication in community level. There was some compensation strategy for the overtime activities, and they can say some to motivate the healthcare workers for their additional work. And population willingness, which came from the Soviet Union time, mostly among the adults. So this was the key, we can success which Tajikistan can show during the pandemic response. Over to you.
Great. And it's probably worth mentioning that Tajikistan did not initially receive mRNA vaccine. That only came a little bit later in the pandemic when you were able to get that cold chain. But thank you very much for those responses. Let's turn it over to Bangladesh. You ended up with a very high rate of vaccination and high acceptance as well of the booster doses. But this wasn't the case from the very beginning. What challenges did your country face in getting access to vaccines, and how did you end up getting so many people vaccinated?
No, thank you very much, Lois. The country has very strong capacity in vaccination EPI program, has a long day experience and human resources in terms of mass vaccinations. During that time, the vaccinations, the government health sectors, or the all Department of Health sectors, as well as some local government, administrative local government, and also some other administrative support, local administration support, were in favor of health ministry. So vaccine acceptance is another area. People are very, do not have hesitant. Vaccine hesitant is not a problem in Bangladesh. So, and there is a challenge of one challenge of during availability of vaccines first. So bilateral, initially it was the government had initiative to procure vaccine bilaterally. Later on COVAX facility, but during first Serum Institute of India vaccines, which is AstraZeneca vaccines, which has been developed by Serum Institute of India, which we procured, even advanced money we procured that way. So, but during that time, after one shipment, it was interrupted due to crisis of India government barred to supply vaccines to other countries. So later on, we try to explore other sources, and we procured it from China also, Sinopharm, Sinovac, like this. And later on, we procured a lot of vaccines we got from COVAX facility. And later on, some donation from Pfizer vaccines from USA, the sources. So, and for usually the problem, the vaccine storage facility was adequate, 2 to 8 degrees Celsius vaccines. But for vaccines, minus 70-degree vaccines, preservation was initially a challenge. But however, it has been mitigated by private support also. Private sector's facility were utilized. Pharmaceuticals facility were utilized. So overall, and people were trained. And Bangladesh's strength is that vaccination program, the trained people were available. And one day, mass vaccination, 10 million people were vaccinated in one day. So these are the purpose. These are the vaccine administrations, vaccine supply and procurement. And also in terms of vaccine lot release, regulatory support to DGA from DGDA, we provided instant support to to government, to health, to DGHS. Because we got the vaccines, we try to do it expeditiously, very expeditiously, lot release. We get the lot release certificate from country of origin and physical checking, we gave lot release, issued lot release. So, and also cold chain facility, we observed the cold chain facility during vaccine transportation and vaccine storage. So the cold chain, we also simultaneously we observe the cold chains within the acceptable limit, then we do it. So lot release were done instantly. And also the emergency use authorization, a lot of 9 vaccines were registered during that time. So Public Health Emergency Committee was formed by DGDA through ministry. Initially, we did not have the mandate of emergency use authorization, but we did it through notification by Ministry Gazette notification, emergency use authorization by DGDA and NOC, which
So
were
you really benefited from a number of things already,
Yes.
having a strong system, being able to
Yes.
bring in the vaccines that you needed to bring in,
Yes.
and the demand that the country already had. Let me just turn it over, if I could, to Dinesh for a moment. And I'm wondering if you can comment on just a few of the more common lessons learned that you've seen across the region.
Thank you, Lois, and yeah, glad to be here. I think I can share the experiences of what ADB went through. As the crisis hit, ADB was very prompt and came up with a 20 billion package for emergency supplies, including PPE kits, as well as lab diagnostic kits. Then we also came forward with a vaccine access supply for 9 billion to support our countries. So while financing is important, but there were certain factors which I'd like to highlight, which became a very critical factors during our support to different countries. So if we divide vaccine delivery, there are 2 kinds of things. One is the availability of countermeasures, and we'll talk about vaccines, therapeutics, and diagnostic availability. I'll come to it in the second part. The most important part also was a vaccine delivery system. This is for perhaps the first time when adult vaccination was taken at such a high footage in Asia and Pacific. Most of the countries in Asia Pacific don't have even the routine influenza vaccine which is given in the Western world. So this was perhaps the first incident where they were talking about adult immunization. And let me tell you, my experiences of South Asia and other countries was that the vaccine delivery system rose to the occasion. There were 3 important factors. One, for example, even when they required a Pfizer vaccine, the ultra cold chain, which was never used in these areas, were upgraded using biotechnology, storage spaces, and other labs. So it was made available. The digital system worked very well. So for example, in Bangladesh, we had the Surakha portal. In India, we had the COVID platform, where you could track each batch of the vaccine, right from the administration to the AEFI whenever reported. And thirdly, of course, the human resources surge, which they mobilized. And you can see different countries were at different paces for this. So while the vaccine delivery system did well, we definitely had issues with the vaccines availability. We had a condition where we had the finances, countries had the vaccine like India, but Covaxin had not got the go-ahead WHO EUL from WHO, and we could not supply those to the different countries. We had the different rates. For example, if you see the chronology, by May 2021, 6 months down the lane when the first vaccine was authorized, the developed world had about 60 COVID-19 doses per 100 people, while the developing world had only 0.8 doses. And this dichotomy continued even till December 2022, when 77% of the developed world versus 50% of the developed world for the vaccines. So I guess when the vaccine administration was good, we had issues on the vaccines availability, as highlighted by different speakers. And I think we can discuss this, how we can mitigate this further. But Sherry, if you allow me, I will also, like if Najib can come in here from, Najib is my colleague from ADB, and he had worked on Mongolia for the same. So in fact, he can also share his insight if he's available. Najib, are you there?
Andrew, I think you might have to unmute him.
All right.
Let's come back to him in a little bit and see if we can figure that out. So thank you for talking about some of the challenges across the regions. Vaccine supply is certainly one of those. There's also a question in the chat about the cost per dose of vaccines. And I think one of the things that we've seen is that in various places, particularly when there was the bilateral procurement, the cost per dose really, and this is just for the vaccine product itself, not including the cost of delivery, but that really went up. And I do believe there were some other initiatives to look at the total cost of delivery of vaccines to an entire population and to one that was not traditionally served in the past. So some things could go through usual platforms, but to reach that many people, there's really a different model that needs to be looked at. Let me just move on for a moment and we can come back to some of these questions, but looking at some of the investments and technical assistance that countries would benefit from, let me start with COSAM, if I could. Now that you've vaccinated a large part of your population, what are the types of assistance that you still need and that you would benefit from to be prepared for the next pandemic?
There are many priorities to be addressed in the country for this, to be better prepared and have the better response. But based on my discussion with my peers and colleagues in the Ministry of Health and the other key and line ministries, the following priorities can be considered as the most important. So first of all, this is running the post-pandemic review. The country is not evaluated or assessed. This is the post-action review. So, and the post-action review is important to analyze and come up with the critical summary of the measures implemented during pandemic and in the pre-pandemic period as preparedness activities. And identify, lesson learned, and consider possible alternative responses and preparedness. And we can say the scenarios. Based on this review, again, the review of the National Pandemic Preparedness and Response Plan, including the National COVID-19 Deployment and Vaccination Plan. Among the other priorities, I would like to mention it could be the resource mobilization strategy and adequate funding, addressing the health force challenges, I mean the training, their preparation, stockpile resurgence, communication strategy such as the preventing myths and the other rumors that do not have any scientific base, improve epidemiological intelligence, particularly event-based surveillance and early warning system to timely identify risk level and switch on preparedness and response activities.
Great.
Establishing core response capacity, including the competent or trained health human resources, replenishment of the stockpile, including the vaccines, PPE, equipment, and strengthening cold chain capacity to be able to use different types of the vaccines, including cold, sensitive vaccines like which requires the ultra cold chain. And the last is that we have some capacity which was developed during the pandemic response thanks to the international aid. But the pandemic ended.
Mhm.
But this capacity should be used, should not be light idle. And one of the options is to customizing or optimization, for instance, diagnostic system to respond to other emerging infection diseases. Which country is thinking over this?
Yeah.
All
So-
above can be considered as for the technical assistance and the capacity building activities.
Great. So our hopes are really for sustainability of some of the gains that you made. And I don't know, I don't think you had mentioned digitalization or really moving into the ability to record things electronically. Will that also be an area that you'll be focusing on for the future and improving use of data? Great.
Yes, this activity already is running in the center of the immunoprophylaxis. So that thanks to the WHO support, the country is trying to improve the electronic management system for the vaccine inventory.
Great. Good. Thank you. Let's turn to Salahuddin and Naeem. Bangladesh is already investing in vaccine manufacturing and strengthening your regulatory. Why is that a priority for you? Could you expand on that a little bit further?
No, thank you very much, Luis. Asian Development Bank, ADB, rightly captured and rightly identified the gap of Bangladesh. You know, the local production of vaccine, capacity building of both regulatory strengthening as well as local production. And vaccine, always vaccine for vaccine. Regulatory strengthening is very essential, inevitable for strengthening regulatory system and capacity build of regulators. Because regulatory authorities should have maturity level 3 at least for vaccine countries, vaccine pre-qualification by WHO. So Asian Development Bank has rightly identified, gap analyzed and identified and addressed this issue. And this is why they have this program, DPP, they have 2 projects they have taken for establishment in public sector, essential biomanufacturing plant, vaccine manufacturing plant, and also diagnostics and biotherapeutic products for essential drug company owned by the 100% share owned by the government. Simultaneously, they have agreed, they have supported with $50 billion to regulatory authority for strengthening regulatory systems for vaccines, diagnostics, and therapeutics. So DGDA is in the pipeline of, on the way of achieving WHO maturity level 3 on the verge of, and is working for functional NRE, later one maturity level 4, 3, and consecutively, subsequently to achieve maturity level 4. So, and local production, you all agree with me that local production is the way of overcome and vaccine research. So for establishing in private sector, public sector vaccine research, it has planned to research R&D development, vaccine development, and as well as vaccine manufacturing, and simultaneously regulatory strengthening. So this is the way or the learning, the outcome of this pandemic, COVID-19. So to overcome the future pandemic, to face the future pandemic, this is the way forward.
Yeah.
Thank you.
Thank you. And we regulatory strengthening in particular, and the ability to bring in local manufacturing can be a real benefit to not only Bangladesh but to the region if done appropriately.
Exactly.
So let me turn it over to Tandon. So Bhutan is a small country, and you're able to do things that others cannot. But in terms of investment and technical support, you still would like investment. What are the things that you think would make the biggest impact in a country like like Bhutan?
Okay, Louis. In Bhutan, we have a unique mechanism of ensuring the funding of essential medicines and vaccines. So there's a trust fund, the Health Trust Fund. So that is supposed to actually pay for all the essential medicines and vaccines. However, for vaccines like pandemic vaccines, and especially where you need it for the whole population, even the trust fund may not be able to fund the procurement of such large procurements. So obviously resources to procure vaccines would be very helpful. And also, I mean, as we saw from the mRNA vaccines, there are a lot of different requirements, like in terms of cold chain, in terms of logistics. And also we found out that the traditional vaccine delivery system was maybe not adequate enough in terms of trying to reach the vaccine to everybody. So I mean, during the pandemic, we actually did strengthen a lot of these systems to have, to be able to have the vaccine delivery in place. But I mean, since we are talking about planning for the future, to sustain those delivery mechanisms and to have these logistics in place, I mean, these would be very useful.
Yeah.
Maybe if I could just continue. In terms of like the vaccine preventable disease program, it's well integrated into the overall healthcare delivery system, and it's a major component of the maternal and child health strategy. So I mean, it's something which is very well established here in the country, and it's supported by a national immunization technical advisory group drawn up of experts from various areas of the healthcare system. So obviously, if there is a new pandemic and if there are new vaccines, so if they the program and the NITAG, if their expertise could be enhanced, that would also be useful. Thank you.
Yeah, one additional question to that. You said that you built off of the maternal and child health program, but having older adults be the main target in here, what are some of the differences that you saw, or some of the opportunities you saw to be able to address the needs of that particular population?
Okay. So in terms of, the vaccine preventable disease programs looks after all vaccine delivery in the country, irrespective of which age group the vaccine targets. And we have had experience in the past where, we introduced HPV vaccine for girls, and we did a mass campaign from age 12 to 14. And earlier, we introduced MR vaccine, when rubella was first introduced. And that targeted women up to the age of 49. So the experience has been there, and there have been other mass campaigns.
Great.
So like, yeah.
Thank you. And I see Najib is on. So I'd like to return to Najib and get some of your comments as far as either lessons learned or experiences that you've seen in the region.
Thank you very much, Lois, and I hope everyone can at least hear me. So I'm a ADB staff and working with Dinesh. And I have to say, I've never worked so hard in my life as when I did when the pandemic happened and we had this unprecedented situation. I think the key lessons learned was we were in an unprecedented global situation where, well, we had vaccines, we had tools, but what was authorized to be used was not available. And what was available to be used was not authorized by, global regulatory agencies and regional regulatory agencies. That was a huge amount of stress. And I think some of the talks today really just emphasizes these points. I hope we can avoid that situation in the future. I think some of the analysis you showed vaccine nationalism. Vaccine nationalism is where countries that have the capacity and you could say the power to direct manufacture and export vaccines really had a strong advantage. And it is even beyond the remit of the ministries of health. It went to ministries of foreign affairs and maybe head of state to actually make some of these decisions. So that was really interesting. And my final point would be, just reflecting, and this is by no means ADB's point of view, but just my personal point of view as a public health expert. If we could avoid situations and have like that and have more self-reliance for countries in vaccine and even medical supplies, that would be fantastic. And it just so happens that, Dinesh, with the strong partnership of the government of Bangladesh, is actually moving in this situation forward, which is really great, I think. That's not a plug on ADB. I think other agencies are doing the same thing. But I think just to avoid the situation, that would be great. Thank you very much.
Yeah, and Dinesh, let's take that and also to answer the question about, what is ADB doing to address the issues of supply security and, perhaps this vaccine nationalism.
Thanks, Najib, for, I just turned the gun on you and you were spot on. Andres, I think we'll need to see this vaccine manufacturing in a more holistic terms. We have seen Ebola crisis happen. Many countries went for vaccine manufacturing and there was a glut of vaccines and many vaccine plants are idling out. So I think it's important that we must understand every country may not be able to produce vaccines because they may not have sufficient demand. And we have some very small countries like Bhutan or Maldives, which perhaps will not be able to produce vaccines, not even Nepal. So the normal benchmark is that if you have a birth cohort of minimum 1.5 million per year, every year, and you have a facility which can produce roughly about 50 million vials, that should be more or less could become self-reliable, and that has a good economic feasibility. So that's a primary I'll start with. Yes, during COVID crisis, while COVAX was a great initiative, but somehow I think it did not have a bigger base of vaccine supplies to be sourced at, and it had also a lot of constraints. Somebody did ask about the pricing. Sorry about that. Since we are bound by NDA agreements for most of the suppliers, we can't share it in open. But COVAX supplies, yes, to a good extent, were less than $10 per dose. Little more than $10, less than $10. But yeah, so I can share about the COVAX ones, but not for the other manufacturers. And yeah, some were pretty high at that time when they required vaccines.
Yeah, and
So
they are available on the UNICEF market dashboard, the COVID-19 market dashboard. So the
that's pretty
private,
that's pretty general. That's pretty general, but I can tell you many manufacturers played torrents, and there was almost a bidding going on for different countries and who will give the maximum rate they will go. So we have seen the best and the ugly part of pandemic through this manufacturing of vaccine and supplies of vaccine. And there were instances where the agreements were signed and not honored. So we have seen all those phases. So that brings to the point one, that we need to have advanced purchase agreements. We also need to have a diversified vaccine manufacturing. And to do that, I think Gavi and COVAX, Gavi will have to play a role where they should incentivize different manufacturers, and not only from few selected countries, which I think have more than 60 to 70% of supplies. If I can name it, India and China supplied more than 70% of the vaccines which are applied to the whole world. Coming back to the vaccine manufacturing, yes, vaccine manufacturing is required for diversification, but not all countries. We need to do a good feasibility study first, whether it's feasible to put up a manufacturing plant rather than just importing from somewhere else. Luckily for Bangladesh, it was not only the COVID vaccines, but since they were transitioning out of Gavi subsidy, since they have a good economic growth, there was a case where they also need vaccines for national immunization. So national immunization plus pandemic makes a beautiful example of how it could be feasible, and that's what ADB is considering. So we have, by next year, we will start the manufacturing facility at EDCL Gopalganj. And along with it, I think perhaps more than vaccine manufacturing, the biggest gain has also been on the regulation side. We had not paid much stress on regulation before this. Now countries are fully geared that if the vaccines need to be safe, efficacious, and quality, they need to have at least maturity level 3. And as Bangladesh, they're thinking of even maturity level 4. So is India, Indonesia, Korea, and Singapore just recently got. So I think there's also a demand here where we are saying the regulation or part should also have emphasis. And that's what came out very strongly during this COVID crisis. Back to you, Lois. Thanks.
Thank you. And we're nearing the end of our time. So I'd like to ask each of the panelists to, in 1 minute, make any closing remarks, anything about what you see as some of the priorities going forward, or things that we absolutely must get right. So I'm going to start with you, Salahuddin and Naeem.
Thank you very much, Louis. I would like to appreciate Asian Development Bank, especially Dr. Dinesh Arora. Because he's very he's instrumental to communications with Bangladesh chapter, and he's the head of the mission to Bangladesh. He was looking Bangladesh chapter, and usually during the COVID time, ERPP fund to support government to procure vaccines. And also pandemic other medical equipments and accessories. And after COVID or pandemic finishing, after having finished the pandemic, the endeavor of the planning of establishing the vaccine manufacturing plant in government sector, public sector, as well as strengthening regulatory system, they have allocated 300 million US dollar, which is really we appreciate it. And they have rightly they have a feasibility study and calculation that this industry will be feasible, and Bangladesh will be one of the country who has this capacity, and regulatory authority will be in the maturity level 3 and subsequently 4. So we appreciate this. And local production, emphasis on local production, feasibility, actually where vaccine industry will be feasible, where the market size, at least the minimum market size is there. So this is a very fantastic job that Asian Development Bank has performed. So thank you very much. Few words from Naeem Goldar, my colleague.
Hi. I actually like to thank Asian Development Bank and the for going to finance to strengthening our regulatory system, as well as to enhance the capacity of our local production. Thank you.
Thank you. So let me turn it over to Tandon.
Thank you, Louis. I think in terms of future pandemic, maybe something like what the ADB has just now, the FX, which is set up for COVID-19. And I know the World Bank also has the pandemic fund. So if these things could continue or could be immediately set up for in case a future pandemic does come in, it would be very helpful to the countries in the region.
Great.
Okay, thank you.
Thank you. And Kosum?
Taking this opportunity, I would like to express my appreciation to the international aid provided by ADB, World Bank, USAID, and other on the developing countries. So for the priorities of the country, I would also already mention. I would add to that just the capacity building. I mean, with regard to workforce training, refresh training on the vaccine administration, cold chain management, vaccine inventory, pharmacovigilance, and increasing the funds for the crisis response. Also, as I mentioned earlier, this is the optimizing the diagnostic capacity which was built during the crisis response to adapt it for the response to the emerging infection diseases. Back to you.
Great, thank you. And before I turn it back over to Dinesh for his closing remarks, I just wanted to again thank all of the panelists for your great insights. One of the things that we've seen today is that there's certainly huge opportunities in being able to strengthen. There was really remarkable progress in being able to deliver something that I think nobody ever expected that countries would be able to do. So the ability to make things happen was great, but there still is a need for investment, and those investments will need to be prioritized. So moving forward, the goal is to bring the countries back and help prioritize those investments and share the lessons learned further. So we're very thankful for ADB's support in being able to do this. And I'd like to turn it back over to Dinesh for some final comments.
Thanks, Louis. And let me start with saying that I'm really grateful to IVAC and Johns Hopkins University for conducting this study on behalf of ADB. This is very useful and will in fact provide us a right policy framework of how we move forward as not only for COVID pandemic, not only for the pandemic preparedness, but also how adult vaccination becomes part of our immunization plans in different countries. I think that can be a thought for some other day, which we can discuss. For me, Lois, if you didn't ask me this question, that what one thing I would love. As a public health expert, I have seen that most governments do panic and then forget. Has happened in the past pandemics too. And I think this is where everybody has a role to play. The audience, which reflects the public health experts, academics like you and Johns Hopkins University and other universities, banks like us, health experts on the panel, we all need to see that this fatigue doesn't set in. It's important that the momentum which was generated, I remember the Churchill's words of "let never a good crisis go waste." So I think I'm a little on the fearful side that as COVID wanes, governments may lose interest in public health for a short time, and that could be counterproductive. So it's our responsibility of all of us on this call to ensure that we keep on remembering and take the right steps forward on how we are going to have pandemic preparedness. As my friends mentioned, Pandemic Fund from G20 was a great initiative. We are doing a climate and health initiative under the Indian presidency. There are COP28 is coming up for the first time as a World Health Day. So it's important that we all work together and get this momentum going. From my side, extremely grateful to Sherry, Lois, and William for this excellent session conducted by them. Extremely thankful to our colleagues Tandem, Qasim, and my dear friend Mr. Salahuddin and Naim from Bangladesh, under whose guidance we are working very closely with them. And thankful to all the audience and my colleague from Asian Development Bank, Najib, who actually is a One Health expert working great on Pacific and the Central West Asia. And we hope that we all keep on working together like this. Thank you. Back to you, Liz.
Great. And with that, I'd like to wrap things up and thank everybody for joining. We will be sending out the slides afterwards to make this available along with a recording. So thank you, and have a good evening or morning or afternoon wherever you are. Thank you.